Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. Go subscribe there. You can get a free 31-page PDF on the top 200 drugs. Simply an email is all it's going to cost you, so kind of a no-brainer there. Great resource if you're out in practice or if you're preparing for pharmacology exams or board exams where medications are tested. So go snag that for free at reallifepharmacology.com. All right, let's get into the drug of the day today, and that is Cephalexin. Brand name of this medication is Keflex, and this is a cephalosporin, as you could probably imply from the ceph beginning of the word there, and it is a first-generation cephalosporin. So if you remember, previously I had done ceftriaxone, and as we get to higher generations, we generally get more and more gram-negative coverage. So Keflex, or Cephalexin, being a first-generation cephalosporin, we are going to primarily have gram-positive coverage, and gram-positive bugs include strep and staph species. Those are the most common targets that we're going to use a drug like Cephalexin for. With that said, there is potentially some activity against sensitive certain E. coli species, Klebsiella species, Proteus species, and as we get to talking about indications, urinary tract infection is sometimes an indication for Cephalexin. Generally not a first-line agent, but if we have susceptible species, we possibly can use Cephalexin in certain situations. Now, most commonly where you're going to see Cephalexin used is skin and soft tissue infections. Now, these are often staph or strep type infections, which Keflex certainly will cover there. Other potential infections that may have, generally more gram-positive causes, strep A, so that's like strep throat. Again, probably not a first-line agent there, but a possible option. Endocarditis and mastitis in patients who are lactating. Now, when I mentioned Staph aureus specifically, remember, methicillin-resistant Staph aureus is not going to be covered by Cephalexin. Okay, so MRSA is not covered by Keflex. Important to remember that. Mechanistically, this drug binds penicillin binding proteins, which ultimately inhibits peptidoglycan synthesis or production, and that's going to basically prevent bacterial cell wall formation, which is obviously going to be necessary for the bacteria to keep growing and replicating. Dosage forms are going to be important. Cephalexin does have an oral dosage form, oral capsule dosage form. There is an oral suspension as well, which if we use this in a pediatric patient, obviously can be helpful, or patients that maybe have difficulty swallowing bigger tablets or capsules there. Now, adverse drug reactions. As you could probably anticipate, like with most antibiotics, and often very similar to the penicillin antibiotics, these drugs, or Cephalexin, can cause GI upset. So with regards to giving with food, it can be given with or without food. Obviously, if we run into that GI upset, that's probably the first thing we're going to do is say, hey, are you taking it with food? Or, yeah, go ahead and take this with food if you weren't before. Other GI risk, diarrhea can certainly happen. There is risk associated with the use of Cephalexin, as with numerous other antibiotics, of C. diff infection. Rare potential adverse effects, hemolytic anemia. Hypersensitivity reactions can happen. Allergic reactions obviously can happen. And that brings up always an interesting question regarding cross-reactivity. So you've got a patient that has an amoxicillin allergy, for example. I always inquire and ask questions about what that allergy was, okay? So use some clinical common sense there. So a patient reports amoxicillin allergy, you want to use cephalexin or it's being prescribed. First, get the details. Okay, what was that reaction? Did you have diarrhea? Did you have nausea? Did you have vomiting? What was the specific reaction? Why is amoxicillin listed on your allergy or intolerance list? If it is something that's obviously, an irritant or adverse effect, like diarrhea, for example, that's a classic example where I probably am not going to worry too much about giving cephalexin. Now, if you've got a patient on the flip side with Stevens-Johnson syndrome, life-threatening skin reaction, that's a patient where I'm going to step back, probably do a little bit more research, and also potentially look at alternatives, because there has been situations where there is cross-reactivity with cephalosporins. And I'm not going to get a ton into the weeds on this podcast episode, but one of my friends at idstewardship.com, pharmacist, infectious disease guy, good guy, he has an article on cross-reactivity between cephalosporins and penicillins, and it's a cross-reactivity between cephalosporins and penicillins. A story of side chains is the name of that article. So if you want to search ID Stewardship and the name of that article there, it's a good little rundown of kind of that cross-reactivity potential and how the chemical structure impacts that risk. But again, I'd say first just start with the basics. Start with common sense. Okay, what was the reaction? How severe was the reaction? And that'll get you a long ways typically as far as if it's okay to use cephalexin in somebody with an amoxicillin or penicillin type allergy. All right, let's talk kinetics here briefly. So renal elimination is significant. So generally in patients where that's significant, we've got to look at their past history and their renal function. And dosing is based upon renal function. So if you know a patient's got a diagnosis of CKD, check out that renal function, see if we've got to dose adjust that cephalexin. Half-life is very short with cephalexin, approximately an hour. Again, this is going to depend upon the patient's renal function because, again, it's significantly renal eliminated. So obviously, worse renal function, that drug's going to probably hang around a lot longer, and it's probably going to have a longer half-life. Normal adults, might be around an hour, give or take, for that half-life. So that's generally considered a pretty short half-life for sure. With that said, how does that relate to dosing and administration? So generally, cephalexin has to be given quite frequently, 2 up to 4 times per day. And obviously, the more and more times that a patient has to take a drug per day, the more and more likely they are to forget. So that can be an adherence issue with cephalexin because it has such a short half-life there. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for pharmacist board certification study material like BCPS, ambulatory care, geriatrics exam, BCMTMS, NAPLEX exam, go check out meded101.com/store, S-T-O-R-E. We've got a growing list of resources there that can help you pass your board exam. In addition, if you're a nurse, physician, med student looking to hone your clinical practice skills, we've got books on case studies, clinical pearls, drug interactions, all sorts of good stuff there. Specifically for nursing, we also have a nursing pharmacology book, which you can find on Amazon. So Med 101 Guide to Nursing Pharmacology. So go check that out. Support the sponsor there as well. All right, let's finish up with drug interactions. First and foremost, I'll mention Warfarin. Again, with most antibiotics, we're probably going to need to pay attention to the INR. Usually it's going to go up for virtually most antibiotics, and cephalexin fits the bill there. Obviously, one of the big exceptions being rifampin, that can potentially reduce concentrations of warfarin. Aminoglycosides, the risk for nephrotoxicity could potentially go up a little bit with the use of cephalexin in combination with aminoglycosides. Can't say I've ever seen that combination used in clinical practice, but who knows? There might be a rare situation there. Metformin concentrations could be increased with the use of cephalexin. Again, probably not a severe, life-changing interaction, but it is something to potentially think about if you're seeing more adverse effects from metformin for some reason as a course of cephalexin is going on there. Probenecid, an older agent used in gout. It's been a long time since I've seen it, but this can increase concentration of cephalexin. And then one I did want to mention to supplement, zinc can actually bind cephalexin potentially, leading to lower concentrations and ultimately could cause treatment failure there. So I think that's going to wrap up the podcast for today. Hope you found some useful clinical practice pearls there. As always, support the sponsor, meded101.com/store, S-T-O-R-E. And of course, go sign up at reallifepharmacology.com. Get that free 31-page PDF on the top 200 drugs. If you enjoyed this episode, found it helpful, leave us a rating review on iTunes or wherever you're listening. Share us with students, preceptors, faculty. Hopefully, everyone can help learn pharmacology a little bit better from this podcast. That is certainly my goal with the podcast. If you want to track me down, mededucation101@gmail.com, or you can find me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Thanks so much for listening, and I hope you have a great rest of your day.